Hello everybody. The topic I'm going to share is about management of flare-ups post-endodontic treatment. What's a post-endodontic flare-up? It actually manifests as a pain or a swelling episode. Mostly it requires some urgent treatment. We always refer endodontic emergencies like uninvited visitors at the dinner table. Now you see this lady, this girl, actually she's come with a swelling. It's on the lower left side. It's a post-endodontic flare-up. It definitely needs immediate attention because you don't want a Ludwig's angina or a cellulitis or a sublingual infection to come in. Or this is also an infection during or post-treatment where the doctor may have gone wrong. There may be a lateral opening, a perforation, and we may have to drain the abscess immediately. What are the common causative factors? The factors can be mechanical, it can be microbial, it can also be a chemical factor. Most commonly these factors are attributed to something that goes beyond the tooth. When I say it goes beyond the tooth, it's like debris being pushed beyond apex. One of the most common factors, the last 3 millimeters of the root canal system, if you can't possibly control it in the form of instrumentation, debris gets beyond. And debris can have bacteria, it can have irrigating material, it can have smear layer, the biofilm, all these that get pushed beyond apex. If there's lack of immunity in that area, there will be a flare-up. What you need to understand is, if you follow the simple techniques of watch winding, we are trying to tease and tickle the root canal system, clockwise or anti-clockwise, I think that will be an easy way to work on. If suppose someone wants to do a little balance force technique, then possibly that's even more a safer way to do it. Definitely I'll advise no push-pull motion in cases where you're close to the apex. Push-pull motions are only advised in case of ledge treatments, bypassing or taking care of blockages and not otherwise. Here's another example of how a coronal leakage has happened. It was an interim restoration where the patient went through a treatment, but because of coronal leakage there was an abscess on the buccal aspect. If there's a poor oral hygiene, definitely it adds up to the cause, and of course isolation becomes a very important cause. And suppose there's no proper isolation, like no rubber dam, then again you're in trouble. Asepsis, when I said, it also means about the system. Yourself, your operator and all the system that's around it, you need to actually try and keep good systems in place. After the microbial cause comes the mechanical cause. The mechanical cause often happens because of the operator. It often happens because of, say, over instrumentation or maybe under instrumentation, where you sometimes end up pushing the debris beyond. Like I said, irrigation can go, medicament can go beyond, the sealer can go beyond, and all this can cause a flare-up. If it is an under instrumented case, the bacteria lying in the root canal system itself can get additional oxygen where they multiply in numbers, and the ecological imbalance happens where there's a lot of bacterial load increasing in numbers, which can actually cause for a flare-up. Proper working length determination plays an important role, and that's why you need to work till the minor diameter. When it comes to filling, either you're over or under. Both are actually not very good. Between the both, over is definitely supportive, but when I said over, you're not going past the major diameter. If you end up going there, again, like I said, the PDL space, the bony area may not be conducive for all these materials. There may be a flare-up. We have seen in the past, missed canals have often played an important role in culturing the bacteria in the nidus or the empty canal space, which becomes a reservoir where the bacterial load increases in number over a period of time. Some procedural errors like perforation or instrument separation or any such reasons can also add to a very important cause of a flare-up. But most of these factors that I mentioned, like mechanical, are operator based, which can actually be in your control to try and avoid a flare-up. Last comes the chemical. This becomes an important reason or a cause, but it's definitely can be in your control. But having said that, sometimes chemicals may not act on your favor, they can flow freely. So when you have an apical diameter which is not constrictive, please use diluted versions of chemicals. One of the most potent chemical that we use always is hypochlorite. and we are supposed to use a 5% concentrated. Suppose it's a wider diameter, please dilute the version. I know you may not get a tissue solvency, but you'll end up definitely getting bactericidal effect. But then you need to double the volume. So please be careful. Use color needles, use Leolock needles. They all will help in using these chemicals in a right manner. Extrusion of irrigants, like I said, or medicaments or sealers definitely will play an important role, because if they go beyond, there can be a good chance that the system beyond the apex will not allow this system, and the ecological imbalance always happens. Once you go past apex by instrumentation, the minor diameter, the constriction that you want to get, is lost. It becomes first parallel, then becomes divergent. If that happens, even the apical seal that you want, the seal that you want to get, is not possible. So try and limit your working length to the minor diameter and not past apex. Here's a picture where you see intracanal medicament was intentionally pushed beyond. These are those materials which we were told to do with, like say Vitapex and Metapex, only because it's iodoform. But this may not be a good option, according to me at least, because sometimes iodoform is not good for the body or the bone. There are patients who are allergic to them, and then you may end up having a flare up. So I would possibly not suggest strongly to push material past the apical constrictions. Here are a few more examples where you can see an hypo accident. A hypochlorite gone past due to lack of rubber dam or no controls on the apical area, and see what's happened here. The entire petechial hemorrhages, or it spread entire on the palatal side. These are accidents which you can actually avoid. So you need to manage the entire flare-ups well, and first and foremost is it should be a case-specific treatment or a retreatment, which means the cause what I mentioned, you need to control why it's happened. Suppose you missed a canal, suppose there are lateral exits, try and find them and try and possibly treat them. So these are all pictures where we have tried to treat that extra bit of problems. Here is a case of long chronic case. We see the first picture there. There's a huge lesion, but over a period of time, if you see, the lesion has settled and worked on our favor. It worked on our favor only because we followed all the protocols right, worked till the apical constrictions, used the right medicament, used the right irrigation and the sealer and the obturation. The most important thing being a good coagulant top material. If there's a perforation, repair it the fastest, please. Cover the other canals as you see in this video. You need to try and seal the perforation with a bioceramic material. There's no better material than a bioceramic, like an MTA, a biodentine, a total putty. Condition the area with a diluted version of hypochlorite, sterilize the area, use a bioceramic material with good carriers and condensers, pack the concrete as fast as possible, as good as possible, get a good seal between the endodontium and the periodontium. That's the most important request that I would say if you have had a communication between the endodontium and the periodontium. Suppose the patient has come with a fully blown infection, it needs to be drained. And the best drainage is to drain with a pointed instrument, maybe even a Bart Parker blade, 11 number blade or a 15 number blade at the site of pointing. At the most pointed area, just puncture it and then manipulate with manual or bimanual fingers so that you can drain the abscess away from the gravity. Intracanal medicaments play an important role, and here's one common medicament that we all use called calcium hydroxide, where you need to deposit it. You don't inject, please, you eject the solution. You need to deposit the solution. It's passively placed, then with manual dynamic activation like Gadaparcha here or an activator here, you're trying to coat the material to that space that it needs to be. Calcium hydroxide is placed at the apical 3rd millimeter or up to 6 millimeter. Do not let it go beyond. Having said that, sometimes you might have some material going beyond. It's acceptable, but intentionally don't push it beyond. If a patient has come with an acute infection, if it's come with a flare up with severe tenderness, occlusal reduction, selective grinding also play an important role. You will not possibly grind the tooth in total or chop it in total. Take the bite paper marks, see where it's coming in contact. Those are the places you need to selectively grind following the cuspal inclines. Check the bite of the patient during work, after work, I would say before work, to check these high points. One of the other points has to be a trephination. The trephination is actually explained in surgical way, where you go through the bone to drain the excess pressure built up. But that's called cortical trephination. What trephination I am speaking is going past the major and the minor diameter, trying to open up the apex to a certain size. You can enlarge till size 20, maybe 25, maximum 30. If it drains till then, it's excellent. If it doesn't, don't keep on enlarging to whatever size you want. Beyond 30, you may not be able to reconstruct the apical area. If that happens, the only way left for you is a bioceramic plug. A concrete plug needs to be pushed at the apical end. And as I end this presentation, what we understand is whenever there's a flare up, you need to cover the patient with a supportive therapy. It has to be analgesics like painkillers. Commonest ones given are ketorolac, diclofenac, ibuprofen combinations, or antibiotics like cephalexin combinations, or maybe amoxicillin combinations. These are important so that the infection do not spread to the facial spaces. There are times when we give steroids too, like prednisolone or any other, maybe for that matter. So this is how you possibly could take care of a post-op flare-up. Thank you.